In this first study, we're going to examine a study that focused on a static application of stress to the major ligament or a major ligament of the knee, and that's the anterior cruciate ligament. And so, in this, just to review the anatomy of the anterior cruciate ligament, also referred to as the ACL, it's located deep inside the joint, and the origin of this ligament is located on the posterior inner portion of the lateral femoral condyle and inserts onto the anterior medial portion of the tibia. Now, the anterior cruciate ligament, being a ligament, functions to restrict range of motion, does not eliminate range of motion, but it functions to restrict the motion between the tibia and the femur so as to maintain the stability of the joint. Now, this ligament is very often torn in people that are physically active or people that experienced a slip or a fall. And from a clinical perspective, a very common test, manual test that is used to evaluate if injury has occurred to the anterior cruciate ligament is something called the anterior drawer test. And so in this clinical test, we see that a person with a suspected injury to their ACL, the knee is placed in a 90-degree position while the muscles are attempted to be in a relaxed position as much as possible. And the clinician will apply an anterior directed force, attempting to draw the tibia forward on a fixed femur, hence much like the drawer on to pull that is often pulled forward. Now, based upon Newton's third law, a person with an intact anterior cruciate ligament will generate a reactionary force in the opposite direction. And with the knee in a 90-degree position, this will place unique stress on just one portion of the ACL, specifically the anterior-medial bundle of fibers that make up the ACL. And if the ACL is intact, the tibia will translate in the direction slightly because the ligament does stretch, but the ligament will eventually arrest the movement. If the ligament has been injured to varying degrees, then the clinician will note a relatively greater amount of translation of the tibia on the fixed femur. A second clinical test is referred to as the Lachman test. And the same principle applies here as the anterior drawer test, with the exception that the knee of the person with the suspected injury is placed in a near extended position. So in this particular example, we see a clinician attempting to draw the tibia in an anterior direction. So we have the anterior force being applied, and the resistance or reactionary force, once again here, will come from the ACL, but will particularly stress the posterior lateral bundle as opposed to the anterior medial bundle that the anterior drawer test placed under stress. And so the question we had asked in an earlier lecture is whether cyclical activity, exercise, will produce that ligament softening effect, that stress relaxation effect, through repeated cycles of knee extension and flexion. So this study was published in 2001, and in this particular study, they sought to examine the restraining characteristic of the ACL. And this device here is referred to as an arthrometer that will provide a more objective measure of the amount of anterior tibial displacement when applied to certain force levels. And so, with the understanding that the ACL is the primary restraint to anterior tibial translation, previous studies have demonstrated up to 80% of that restraint of the tibia to anterior translation comes from the ACL. So in this study, they recruited 3 different groups of individuals. So they had 20 people who had experienced no previous injury to their lower extremity, the quote-unquote non-injured group. The second group consisted of 33 people that were classified as ACL deficient. So these were individuals that were diagnosed with a torn ACL at some point and never had surgical intervention to reconstruct or repair that ACL. And the third group consisted of 30 people that had experienced ACL injury and had a surgical reconstruction using some type of graft to repair that ACL or to reconstruct the ACL. So all 3 members of all 3 groups here, the participants, ran on a treadmill at 5 miles per hour for 15 minutes. So not a particularly fast speed, but this is a jogging type of pace here at 5 miles per hour. So knee arthrometer testing was carried out before the treadmill run and immediately after the treadmill run, and anterior displacement was quantified in millimeters of anterior translation. And so what we see here in this figure, we see the results for the amount of anterior translation of the tibia in millimeters, only on the affected side. And so the healthy group, which they termed to be the normal group, were evaluated on what they reported as their dominant leg. And so what we see here, regardless of ACL injury in the people that had healthy knees, prior to and after the 15-minute treadmill run, we see an increase in the amount of tibial translation that occurs with 15 minutes of exercise. And so the ligament softening is a normal occurrence here as it permits the knee to move through its normal range of motion with less of a restraint. The participants that were classified as not having a functional ACL because it was torn and not surgically reconstructed obviously demonstrated a much greater degree of anterior tibial translation as compared to the healthy group because the people in the ACL group did not have that restraining ligament to prevent that anterior translation when the researcher attempted to pull on the tibia. And as a function of exercise, we see slightly less of a pre- and post-exercise increase in anterior translation movement. It did increase slightly less than it occurred in the healthy group. Now, the tibia will translate as well because other tissues that do provide a secondary restraint will also experience that viscoelastic stress relaxation behavior. The participants in the ACL reconstructed group, we can see that when we compare the ACL deficient pre-exercise with the ACL reconstructed pre-exercise, that surgical reconstruction did have a significant effect here on restraining the amount of anterior tibial translation, but not quite to the same extent as was reported in the participants with healthy knees. So the reconstruction graft made the knee behave a little bit, quite a bit more as a pre-injury knee, and certainly much better than an ACL deficient knee. And in response to exercise, the participants that had an ACL reconstructed knee with a graft experienced what we see here, a much less of an increase in anterior tibial translation following the 15-minute treadmill run. And so when we compare the results of the in the pre-post exercise difference in the healthy group and the ACL deficient group, we see that the amount of increase in anterior tibial translation was significantly more than that in the ACL reconstructed group, suggesting that the graft exhibited more of a stiffness profile than the tissues in the normal and the ACL deficient group. And so when I say tissues, of course, with the ACL deficient group, there was not a functional ACL, so secondary tissue restraints also exhibited that stress relaxation response. But the graft, although it did restrain anterior tibial translation, did not exhibit the same degree of ligament softening that the healthy group experienced. And so the results of the study, to summarize, came up with a couple of conclusions here. And the first conclusion is that with exercise, there was an increase in knee laxity, and this is the normal response that biological tissues, the normal viscoelastic response that biological tissues will exhibit in response to cyclical loading with that ligament softening. And the second major outcome of the study was the greater increase in knee laxity for the healthy or the non-injured, in the table referring to the normal group, and the ACL deficient knees as compared to the ACL reconstructed knee. So the ACL reconstructed knee using some type of graft exhibited a relatively stiffer profile. Again, less elastic. It doesn't mean non-elastic. It just means that the response was less elastic and more stiff than the other two conditions. So this ends the lecture describing the first study with respect to static loading.